Hello, everyone. My name is Ioudovski, and I'm a Master of Public Health candidate at Queen's University in Kingston, Ontario, Canada. I'll be presenting a study on HCV testing trends from correctional institutions in Ontario, Canada. To begin with some background, Canadian correctional facilities can be divided into two systems, the federal system and the provincial/territorial systems. The federal system is involved in handling offenders with greater than or equal to 2-year sentences, while the provincial system is responsible for those with less than 2-year sentences. The offender population in Canada is of interest because they bear a disproportionate burden of HCV infection. The Public Health Agency of Canada has estimated that in 2011, about 25% of individuals in federal or provincial custody were HCV antibody positive, a significantly higher figure than the general population. Federal institutions currently offer opt-in screening testing on admission, while in provincial institutions, testing is only offered upon request. There's currently little data available on how these differences in testing strategy has affected testing rates and the prevalence of positive tests between federal and provincial institutions. Our objective was to compare these patterns and types of HCV testing and results from federal and provincial correctional institutions and in the community in Ontario. For our methods, two administrative databases from Public Health Ontario laboratories were linked internally. Individuals were then classified based on their type of test result, and whether they were ever incarcerated, which is defined as tests that were ordered from a correctional institution, or never incarcerated, defined as tests that were ordered in the community. Based on the name of the facility for the EI group, individuals were also classified into federal or provincial categories. So overall, between 1999 and 2014 inclusive, there were roughly 1.7 million tests that were found in the data across 1,055,073 individuals. When split up between our two defined incarceration groups, 2.4% were classified as ever incarcerated, or EI, and 97.6% were classified as never incarcerated, or NI. In the provincial institutions, we saw a higher overall prevalence of HCV antibody tests compared to the federal institutions. As expected, the proportion is significantly lower in the community than in either of the correctional contexts. This table combines some of the information you saw previously in the flowchart. From the roughly 25,000 individuals in the EI group that had HCV antibody testing, 30.4% tested positive overall compared to 9.6% in the community. I would like to draw your attention here specifically to the final row, which shows the amount of follow-up confirmatory RNA testing completed as a proportion of all HCV antibody positive individuals. In the community, we have about 90% of all HCV antibody positive individuals receiving confirmatory testing, whereas in the federal and provincial contexts, we have about 85% and 61% respectively. So in this presentation, I will highlight the three main results. The first is that the rate of HCV positivity was higher in the provincial versus federal context. This may be because of the risk factor-based testing program in the provincial setting, resulting in higher positivity rates. However, we believe that relying solely on risk factors instead of universal screening may lead to missed opportunities of diagnosis and treatment. The second is that confirmation that HCV positivity is higher in the correctional setting than the community setting. This can be partially explained by the high prevalence of offenders with a history of injection drug use, which has been suggested to vary between 28 and 50%. The final discussion point we have is the varied rates of confirmatory follow-up RNA testing across all contexts. Federal and community contexts were fairly similar, but the provincial follow-up rate was lagging behind significantly, at around 61%. A potential explanation for this is the significantly shorter sentences in the provincial setting, as the provincial setting only has offenders that have sentences of less than 2 years, resulting in loss to follow-up. In terms of our limitations, there was a high risk of misclassification between NI and EI groups. There's limited availability of testing from private laboratories, and finally, there was limited data on the linkage to care and treatment after diagnosis. Overall, this presentation was a brief highlight of the differences in HCV positivity and testing patterns between correctional settings and the community. We recommend future studies that explore barriers to HCV initial screening and confirmatory testing in correctional settings to allow for the optimization of testing policies, which can lead to the mitigation of disparity that exists in the correctional setting and expanded care that could lead to HCV elimination. I would like to first acknowledge my co-authors and also thank the Public Health Ontario Laboratory Information Management Technology Group and Public Health Ontario Kingston for our data sources, as well as Merck Canada for funding. I would also like to thank Virology Education and the IVHEM Organizing Committee for giving me the opportunity to share this research. Thank you for listening.